I love when I ask you a question and it leads to more knowledge for our listeners. So thank you.
The good thing about the Institute is that even though someone might not come to my colleagues for interstitial cystitis, if they come for something else, I am sure that we will ask enough questions to potentially uncover if there is a problem, including interstitial cystitis. And since the original treatment approach is something that any physician, not even a physician, can do, since you don't need a prescription for pretty much everything I say, then we can actually try to address those as well.
I don't know how we can address complex illness without complex solutions, complex diagnostics, and very complex research. That needs to be the model going forward if we're going to shift the trajectory of people's health. Welcome to the Hope and Help podcast, where we talk about science and science-based tools for fatigue and chronic illness. I'm Haylie Pomroy, #1 New York Times bestselling author of The Fast Metabolism Diet. I'm also the assistant director of the Integrative Medicine program at the Institute for Neuro-Immune Medicine. Today, we're going to talk about a very interesting subject, and one that a lot of my women friends comment on, question about, deal with. We're going to talk about both interstitial cystitis and bladder pain syndrome, and a couple other comorbidities or things that go on along with it. Of course, I'm very thrilled to have a very dear colleague of mine, Dr. Theoharis. Dr. Theoharis is the professor and vice chair of clinical immunology and the director of the Institute for Neuro-Immune Medicine in Clearwater. He's trained in allergy and clinical immunology from Yale University and the internal medicine at New England Medical Center. Dr. Harris, thank you so much for being here with me today. I can't tell you how many of my women friends and colleagues are excited that we're having this conversation.
Oh, it's a real pleasure, even though we will be talking about medical problems.
We have to do this, though, because we need solutions and answers and ideas. I want to start first with, can you help me define, because there's a lot of misinformation out there about interstitial cystitis and what a lot of people call bladder pain syndrome.
So the term interstitial cystitis is really almost a misnomer because it doesn't really describe something specific, but it's stuck over the years. Most of the patients, who are primarily women, do have also bladder pain or lower pelvic pain. This is why sometimes we call it interstitial cystitis / bladder pain syndrome. We'll get into this in a second. But unfortunately, the symptoms are confusing. They coexist with symptoms that involve other organs. So I'm sorry to say, many of our colleagues just don't believe that this is a real problem. As we already know, similar approaches have unfortunately happened for chronic fatigue, for fibromyalgia, et cetera, et cetera.
Yeah, it's one of those syndromes. A lot of women in our community talk about feeling medically gaslit over this issue. They feel like they go in and they talk to their practitioner about pelvic pain. And I've been, we've in our community, they talk about almost like a bladder on fire, urgency, pressure with urination. They're tested for a UTI and they're told everything's fine, go away and go home. And it's frustrating. So how can someone get an adequate diagnosis with this? I have a million questions to ask you, so I'm going to try and break it down into bite-sized items. So first, how would they get diagnosed?
Well, the clinical appearance is pretty much what you said. It feels like a urinary tract infection. So
right.
You go to your urologist and they'll do urine culture and it will turn out to be negative. So many urologists will say, well, we'll give you some antibiotics. They'll give you antibiotics for 2 weeks, nothing happens. So you go back, we'll give you a different antibiotic for another couple of weeks, nothing happens. So the clinical diagnosis is pain, frequency, that lasts about 2 to 3 months with no documented urinary bacteria growing or any other micro growing.
Can they see anything if they ultrasound the bladder? Is it anatomically different?
No, they cannot. So for many years, the National Institute of Health had supported very vigorously both basic science as well as clinical studies. And while I was at Tufts University, I was actually funded 3 times by the National Institute of Health, and I participated in 2 very large clinical trials as well. Most urologists will actually do a cystoscopy in the office.
What's that?
So they put basically a tube inside the bladder and they look. But most of the time, nothing is seen unless there's a horrible ulcer or something. This is why the National Institute of Health, for the clinical and basic studies, had requested that cystoscopy be done under general or spinal anesthesia, during which time the bladder is distended by putting in normal saline, a physiologic solution. And the reason being is that as the bladder was distended, there were small hemorrhages showing up on the lining of the bladder. That was a telltale sign of interstitial cystitis. However, most urologists don't want to do that, and it is also very expensive. You have to go under anesthesia. But by the same token, by doing simple cystoscopy in the office, it turns out to be negative, is useless.
Hi, it's Haylie Pomroy, your host. Did you know that the world's largest single environmental health risk is air pollution? That's right. We are being bombarded by toxins every single day because they are in the very air we breathe. But don't worry, there is hope. Whether you are dealing with fatigue, mast cell activation, an autoimmune disorder, long COVID, viral reactivation, inflammation, anxiety, or depression, all of it can feel overwhelming. I know firsthand what it feels like to fight to find real impactful solutions to your health struggles. I have been where you are. But one thing is crystal clear. We must address the environmental and toxic burden in our bodies. Let me help you do that. Go to HayliePomroy.com/detox and download my free Detox Decoded Masterclass. I will teach you nutrition and natural therapies to help your body eliminate toxins. Let's give you a fighting chance. I cannot wait to see you there. There's a lot of theories about this, and that's why I was excited to grab you and ask you for some true science around it. A lot of times, individuals that have a tendency to have a lot of allergies or food allergies or environmental exposures, this is a common symptom profile that we see in these patients. Why? What's the correlation?
I've called this, and I've published almost 40 papers in this topic over the years. I've literally called this an allergy of the bladder.
An allergy, yes, that's what we see, an allergy of the bladder. Sorry to get excited about it, but women that deal with this, they get told it's like you want to itch your eyes and the broken capillaries in your eyes, but you feel it in your pelvis.
But as we discussed for other episodes, the immune cell called the mast cell that is involved in allergies can also be triggered by substances that are not allergic. That's why I try to avoid the word allergy of the bladder. I'd rather call it mast cell activation of the bladder.
Right.
Now, having said that, we published numerous times that the mast cells in the bladder are activated in these patients. And in fact, the urologists in Europe do biopsy the bladder wall. It's called the detrusor muscle. And if they see more than 30 mast cells per high power field, they do call it mastocytosis of the bladder. But they consider that a subcategory of the overall interstitial cystitis. That's fine. But this is one of the problems that my colleagues have been facing. What do we call mastocytosis? Because so far, as we've discussed in other episodes, mastocytosis is considered only if it shows up on the skin or your bone marrow. So what happens if it's in your gut? Technically, it is gastrointestinal mastocytosis. Same idea. If it's in the bladder, it's bladder mastocytosis. But since we cannot really biopsy, in the United States, hardly anybody biopsies, then we'll have to say that the mast cells are activated.
So if the mast cells are activated, that means that there's a lot of histamine in the tissue, or histamine in the area?
Absolutely, yes. Not only histamine, but many other mediators that sensitize nerve endings, and that's why you get the sensation of pain.
Wow. Okay.
We had stopped actually publishing in this area up to a few years ago because some of my colleagues had retired. But since then, other colleagues very recently have revisited the issue. And now they say, yes, mast cell activation is very important in there.
So we see it a lot in, and I think I understand the correlation, but I'd love your help in this. We see it a lot in women that are pre-menopausal and menopausal, and there's a significant change in hormones during that time, and the class of hormones, prostaglandins change, and the prostaglandins help to regulate inflammation also. Why is it the hormone shift, the lower estrogen? What's happening during that time period why we see this so often?
Okay, let me address this in different ways because especially the prostaglandins do not actually regulate. So let's leave that aside.
Okay, so no, but correct me. I love that. Correct me, because I sit around and wonder. I have no idea. That's why I pull you in.
So prostaglandins actually are associated with good and bad things. So we call it the good prostaglandins and the bad prostaglandins.
Okay.
So prostaglandin E, for instance, tend to be the good guys. They open up the bronchi, they protect the lining of the stomach so we don't get ulcers. Prostaglandin D and prostaglandin F are the bad guys. That's why, in general, when I see your supplements being sold or other podcasts, etc., they just use some general terms that really confuse everybody because
right.
They're a little more complicated. Now, let's start with the fact that many patients do show up with what we call otherwise comorbidities. So they might have allergies in general. They might have fatigue, if not necessarily chronic fatigue. They might have fibromyalgia. So they show up basically at the urologist because that's the most presenting symptom. And then they mention all the other symptoms. And at the end of the day, they say, oh, you're crazy. You can't have them.
So it's not necessarily just a bladder disorder. It's a systemic disorder that's manifesting in the bladder tissue?
Well, not quite. What we call interstitial cystitis, it is actually in the bladder or in the lower pelvis. It's just that so many other things seem to be happening at the same time that one wonders if the pathogenesis is actually broader than that. So I agree with you from that point of view. But I wouldn't say that necessarily interstitial cystitis is a systemic disease. Now, there are a few things that we absolutely have to make sure we do before we move forward. There are no objective markers. There's nothing you can measure in the bladder so far that can tell you you've got actually interstitial cystitis. In fact, we're very interested in doing that. But since we know that allergic-like problems or activation of the mast cells does participate, then addressing those would only do actually good to the patient because we would be addressing those problems and indirectly potentially reducing the symptoms of interstitial cystitis. In addition, we know that stress is a major trigger.
Okay.
We know that for allergies, we've known it for chronic fatigue and fibromyalgia. It is definite a trigger for the bladder. And we and others have shown that the first hormone released under stress, that we thought it was released only in the brain, it is actually released in the bladder. We've measured it.
What is it?
So it's called corticotropin releasing hormone, or CR8. Unfortunately, it is not measured in clinical labs, but we and other colleagues have measured in the bladder and shown that it correlated actually with severity of symptoms. So reducing stress, however we can do that, is really an absolute must. Now, for that reason, and because it's such a complicated problem, last year, just about this time, NSU actually sponsored a conference at Clearwater where we had 3 of the best-known urologists who came. And I participated in it. We had about, I think 90 or so participants. And what was amazing to me is that we sent out 500 emails and packages by regular mail.
Right.
Every urologist in Florida invited them. It was actually free. Only one urologist actually joined. So that tells us that to this day, still urologists don't believe that this is a real problem.
Hey guys, it's Haylie, your host. I wanted to bring to your attention the possibility of coming in and doing a study with us. It is called the COVID UP study, and UP stands for Understanding the Post-Viral Phase. You have to be local in South Florida. There are 2 phases of this study. Let me give you the phone number. It's 305-275-5450. And the email is INIMresearch@nova.edu. We are currently looking for patients that are dealing with post-COVID, long COVID. We have 2 phases of that study. Please contact us and see if this could be an opportunity for you to get the care and information that you need.
Hola, soy la doctora Ana Palacio, de la Universidad de Miami. Me encantó participar en el podcast de hoy y quería invitarlos a considerar el estudio COVID UP. Este estudio está tratando de determinar por qué las personas no mejoran después de COVID. Si les interesa saber más de este estudio, por favor llamen al número 305-275-5450 o pueden escribir al email INIMresearch@nova.edu. Les agradezco mucho su interés y los vemos la próxima vez.
So this is one of the, I don't know if we would call it a syndrome or a disorder. This is one of the issues in our bodies that there's not great treatment for it, right? There's the medication that is, if you're diagnosed with it, the medication options from a pharmacological perspective has a ton of side effects. And so can you talk to me? So I wonder sometimes if it's like, well, we don't know how to solve the problem. We don't know what to script for the problem. Then let's just kind of bury our heads in the sand and pretend like it's not a problem. It's much easier to tell a woman that, give her macrobid. She doesn't have a UTI. I don't know, tell her to do more Kegels. I mean, I when you read the chat rooms about this disorder, what women have been told is just so heartbreaking. But do you think some of it is because there's not a good drug that someone can just prescribe for it?
Absolutely, yes. So almost 20 years ago, a drug was approved with a very, very bad study by the name of Elmiron. And subsequent studies did not actually show that it worked, but it stayed as an approved drug in the United States and elsewhere. At about that time, when I was really involved, studying this problem, I kind of felt, well, what is it that we are trying to address? If the bladder lining is being destroyed, can we help it fix itself, so to speak?
Kind of those, can I ask you, those broken capillaries that they see when they distend the bladder under anesthesia, can that be why we lose, female incontinence, right? Why there's leakage, why we have an urgency? Is it the irritation or is it the damage to the tissue?
Well, the irritation or the damage will certainly contribute to the pain that people feel.
Got it.
The actual microbleeds probably do not contribute directly to the frequency.
Got it.
To the nocturia, which happens during the night, you get up. And we used to say that, keep on drinking, you clear out whatever toxins there are. But you basically compound the problem because now you're drinking a lot, so you're going to be going, even more. So it almost doesn't make sense. So the first thing that we actually saw is what is the bladder lining made of? And it's made of primarily molecules that stick out from the wall into the lumen and keep the urine kind of away from whatever damage might have happened.
Wow.
And those are chondroitin and hyaluronate, 2 natural molecules.
Say that again? They're what?
There are 2 natural molecules that make up the protective lining of the bladder. One is chondroitin, and the other is called hyaluronate. These are similar molecules that we have actually in our joints.
So chondroitin, and is it like hyaluronic acid or hyaluronic? Okay.
Right. I try to avoid saying hyaluronic acid because the word acid is a known.
Yes.
As a bladder problem. Yes, you're absolutely
right. Okay.
So let's assume that the bladder lining got destroyed at various parts. Therefore, those 2 molecules are gone. And now we have inflammation on top of it that causes the problems. So what I thought, is why don't we just take hyaluronic acid and chondroitin sulfate and take a natural molecule that inhibits inflammation. We had chosen quercetin at the time, which is a flavonoid, put them together and give them to the patient and see what happens. As it turns out, 20 years ago, we created this supplement called Cystoprotek with a K at the end, which was made by the company Algonaut.com out of Florida. And 2 clinical studies and numerous publications have shown that it does wonders to help actually with this condition. I've had super duper patients in terms of being physicians, nurses, authors. They've given up their careers and they got back to doing what they love to do.
And so it's a natural therapy, right?
So it's not a therapy, it's a natural approach to basically correcting the problem until we find out if, in fact, there is something more that we don't understand as of yet that destroys basically the bladder lining. But in order to catch as many, if you wish, possibilities, since we know that allergies are involved to some extent, we always combine it with an antihistamine for the reason that you asked earlier, that histamine is being released, and we know it irritates nerve endings. So the typical thing would be to ask, for instance, someone to take any one that they can tolerate. Some of the antihistamines are a little pain relieving as well. So one that is not over the counter called hydroxyzine, followed by the name Atarax, Atarax, is a very good antihistamine. It puts you in a deeper sleep at night, therefore you don't get up in the middle of the night. And studies have shown that it has actually pain-reducing properties as well. There is another molecule called doxepin, D-O-X-E-P-I. It's a very old antidepressant, but at very small dosages, 10 milligrams, it can actually reduce the effect of histamine, and it has pain-reducing properties as well. So it's important to combine Cystoprotek with something else. Go ahead.
So just talk to me a little bit more about the micronutrients we're kind of trying to feed the bladder lining, or is the quercetin help lower the histamine level? Talk to me. Can we dissect those nutrients just a little bit?
Absolutely. So from the point of allergy, any substances that contain a lot of histamine are the ones that we try to avoid also in patients that get migraine headaches. It will be the same paradigm in this condition as well. So you try to avoid, wine, cheese, spinach to the extent possible, sardines, avocado, tomatoes, all of those are loaded with histamine. So reduce that part. The quercetin will reduce the release of histamine and other inflammatory molecules from the mast cells and other immune cells that accumulate in the bladder because of the problem.
And so that's the quercetin, that's the bioflavonoid.
Correct.
And where does quercetin come from in this?
So in this case, it comes from Sephora plant, if that's what you're asking.
Yes.
All of the ingredients are mixed with olive pomace oil because we're taking it by mouth, and that increases the absorption from the gut into the bloodstream about 5 times.
So tell me again, the quercetin comes from where?
It's called Sephora plant. It's a natural plant.
Okay. Okay, so it's a plant flavonoid. Great.
Now, depending on the symptoms, this approach may be helpful, but not necessarily to all patients, because when you look into the bladder after distension, in many cases, 30% of the cases, there might be ulcers that are called Hunner's ulcers, Hunners. If you do have Hunner's ulcers, you literally, the urologist has to burn the ulcers. Otherwise, it's going to be throwing a cup of water on a roaring fire. It's not going to
right.
So taking what I just discussed so far would be fine, but it might not be sufficient depending on what someone sees. That's why it's important for someone to look at that. And there's one more comorbidity that we did not mention, and that is endometriosis. This, as you know, is so common in women, and it causes excruciating pain. Most of the time, surgeon has to go in and remove those areas and the adhesions that are involved. We and colleagues have published a couple of papers where my colleagues biopsied both the endometrial lesion and the bladder lesion in patients that had both conditions, and the findings were identical. There was inflammation, there was mast cell activation, and the hormone that I mentioned, CRH, was very high. So my hope is that by addressing the problem the way we discussed, we might be able actually to get both endometriosis and interstitial cystitis at the same time, to some extent.
And supporting the body and making the body stronger and more resilient and more healthy is always the best approach if we can. And whether some other intervention happens down the road, a healthier patient is going to be a more responsive patient.
Well, the typical treatment, I can call it treatment because I'm not really treatment, especially by urologists, would be to dilate the bladder. And they think that if you dilate the bladder, eventually it will take a few months for problems to reoccur. Then you're going to have a period of a few months that you might be okay. It's a horrible approach because it hurts a lot. There's a company out of Canada that literally copied Cystoprotek, and they made a solution that a urologist can put in the bladder that contains hyaluronic acid and convert it. The same idea that if I put it in the bladder directly, we might have a better effect. It's fine. It costs a lot of money. It does not have quercetin that is anti-inflammatory.
Right.
The only other approach has been this drug, Elmiron, that I mentioned earlier. It's been on the market for a long time, even though the studies have not supported it. However, what has happened over the last few years, a number of publications have shown that if you're taking for more than a few months, about 30% of the people can turn blind.
I've seen that. It's so like I said, in so many of the chat rooms, they talk about, well, this is the only medication, and Elmiron is the one that I've seen. And then we see all the side effects and I go, oh my goodness. Well, I love that we're talking about this. I know that a lot of people that deal with chronic illnesses, so whether it's viral reactivation, right now we're seeing it in long COVID, we're seeing it in ME/CFS. Like I said, a lot of women are talking about it just as they're going through the transition of menopause, where they're having these symptoms and they're getting turned away and told that they have just a non-detectable UTI. So I have just really been saying, partner with a practitioner that believes your truth, that is an advocate for your truth. And so if you're feeling this way and someone tells you, it's all in your head, remind them that that's not what hurts, but also, go to the next and the next and the next until you get looked at appropriately. And in the meantime, it's always good to see if you can utilize, I'm a big food and micronutrients to help nourish a body that's struggling, to see if you give it the right nutrients, if it can right itself, or if it can use those micronutrients to rebalance the inflammatory processes or mast cell secretion. You do a much better way of describing that. So I'm a huge advocate, right? And I love hyaluronic acid or hyaluronic. I love the chondroitin, and I live. Quercetin was a big bioflavonoid support in me overcoming my own autoimmune disorder and creating balance and homeostasis. So I'm really glad that you're talking to us about this. First, giving us validation that this is a real thing that goes on in so many women, and that it is oftentimes seen when there's other imbalances in the body.
There are at least two other natural molecules that one can use to help along. One is the molecule d-Mannose.
D-Mannose, yes.
Because d-Mannose is more helpful if one has actually a UTI, but it acts as a decoy, and bacteria bind to it that can be removed from the body. So who knows if someone also might have what we call a subclinical infection? Because we usually call it infection if we see 100,000 microorganisms in the microscope. But what if you have only 2,000, but you're so sensitive, you will still cause problems.
Right.
And the other is Aloe vera is actually quite useful.
What is it? Say that again.
Aloe.
And what form does that come in?
It comes as a powder, for instance, and you can mix it up with, food or juice or whatever. But it sort of covers, or at least we think it covers the bladder wall, along with everything else we said. So I've always found it useful.
That's good.
I would recommend both of those in addition to what we discussed.
That's great. And what's nice is if you try it and it works, that's great. And if you try it and it doesn't work, that's okay too, And so I always love, I am, me, I am a big proponent for nurturing the body that's struggling so that it can do we're always striving for homeostasis. And if we just stop for a minute and think about how amazing it is that when we get a paper cut, we start the healing process immediately, and that's absolutely nutrient dependent and not drug dependent, right?
Right.
The healing process is a nutrient dependent process. And the more you're struggling, the more your nutrient demand is present. And so the more we need to nourish and support our body. I just want to ask you one other question. Do you ever see any correlation with children and bedwetting?
Well, first, I never had experience with children, either directly or indirectly with the problem. So I don't know. And the very few, if any, reports of interstitial cystitis in children, even though there are some reports about adolescents, so I still don't know. However, I do know that both allergies and stress can actually cause bedwetting. And that's why I'm a very great proponent of giving Atarax or hydroxyzine for the reasons that I mentioned. It's both an antihistamine, it puts you to deep sleep, and all first generation or the older antihistamines are also anticholinergics. And it is acetylcholine, the neurotransmitter, that basically constricts the detrusor muscle and opens up the sphincter and makes you go. So by giving an anticholinergic, you're reducing the urge as well. So one can do fairly well. However, in certain cases, we have to worry about other things if it is mostly frequency and there's no pain and no other clinical signs. Because there's what we call neurogenic bladder, where one can have frequency without necessarily pathology inside the bladder as such. There's also maybe 1 in 20 or so individuals that urinate a lot because they lack antidiuretic hormone. We call it ADH. So before I go crazy, I will always ask for an ADH level just to make sure. And at the same time, I will also ask the patient, do you have any headaches, migraine headaches? Do you see double? Because if all of the symptoms are together, I suspect a benign adenoma in the pituitary gland. Because the pituitary gland is in two parts. The anterior part releases all the sex hormones, growth hormone, etc. The posterior part releases the antidiuretic hormone, as well as oxytocin, which is a hormone that prepares the mother for
breastfeeding. Yeah, we call it the love hormone. Yes. So, okay, I'm fascinated.
It can be pressing on the part of the posterior pituitary, and we call that diabetes insipidus, because you're lacking ADH. So the good thing is ADH is in the market, you can give it. So it's called desmopressin. So if in fact we're lacking ADH and you can give ADH, and that's the end of that.
So it's ADH, like H like horse.
Correct.
Okay, that's great, because I think so many times, again, we're just turned away, right, with symptoms. And so I love a negative lab. I love to rule things out just as much to rule things in. So I appreciate that. I love when I ask you a question and it leads to more knowledge for our listeners. So thank you.
The good thing about the Institute is that even though someone might not come to my colleagues for interstitial cystitis, if they come for something else, I am sure that we will ask enough questions to potentially uncover if there is a problem, including interstitial cystitis. And since the original treatment approach is something that any physician, not even a physician, can do, since you don't need a prescription for pretty much everything I said, then we can actually try to address those as well.
And it's that. Absolutely. And it's that shift from siloed medicine, right? And I know I feel very spoiled being part of the Institute because I see how it should happen, right? Where we look at the body as a whole. I don't know how we can address complex illness without complex solutions, complex diagnostics, and very complex research. So that needs to be the model going forward if we're going to shift the trajectory of people's health, period. I mean, there's no reductionistic way out of where we find ourselves today.
Absolutely true.
I'm so glad we had this conversation. And Dr. Harris, where can people find Cystoprotek? It's Cystoprotek, K like kangaroo. Where do people find that?
You can find it on Amazon, and they can find it on algonot.com, algonot.com, which is the company that's been making it for 20 years.
That's great. Well, thank you so much. And thank you for giving us permission, to advocate for ourselves. I want to say one last thing. We had a really cool conversation about finding practitioners. And when you talked about urologists not showing up to this conversation, a lot of patients or a lot of us out there are told, you're doctor shopping until you get what you need. And I said, I'm absolutely doctor shopping until I get what I need, because I need to be well. And in order to be well, my story and my truth has to be heard. And I, I'm not out. We had someone that said, that's a bad thing. And I actually say, go find somebody that can help you on your wellness journey. As we go through these struggles with chronic disease and chronic inflammation, it's not that we're trying to collect practitioners, but I'm all for collecting practitioners if you're going in the right direction. I'd love you to have 40 of them or one of them, as long as you're going in the right direction. So Dr. Harris, I can't thank you enough. Our community just absolutely adores you. You're always such an advocate for each and every one of us. And I love to have natural opportunity to give my body what it needs to right itself. So thank you. I really appreciate it. Please come back. Everybody loves you, and we will talk soon.
Thank you very much.